Alive on the moon, Jaro, it's on the pen alive, with your host David Knapp.
Thank you, Clap Track, and happy Friday night. Welcome to a special edition of On the Pen Live. We have got a great interview for you tonight. This week, we had the chance to sit down with the CEO and co-founder of Fractyl Health. His name is Dr. Harith Rajagopalan. And Dr. Rajagopalan has an amazing approach to improving metabolic health, to improving the diseases of type 2 diabetes and obesity. And Fractyl Health is doing some extremely innovative things in their space. I am super excited to bring this interview to you. Yes, you may remember Fractyl Health as the one and done GLP-1 treatment. And we get into that, and we get into a couple of other things with Dr. Harith Rajagopalan. Can't wait to bring this to you. Let me know in the comments if you're excited for this one. Hey, also, did you notice we got a different camera? So you're getting Dave in high def. I apologize in advance. The audio, you may notice, have improved as well. And I want to thank you, the viewers of On the Pen, because without you, without your investment into what we're doing, we couldn't invest back into what we're doing. So we made some major improvements to our broadcast. This is still all a work in progress. As you can see, the framing and everything needs to get worked out. I need to get a makeup person hired, smooth this thing out. But I'm really excited to bring you this interview tonight. Let me know in the comments what you think of it. Dr. Harith Rajagopalan. Friends of On the Pen, I am super excited to bring this interview to you tonight. We have been talking about this here and there over the last year about a treatment that is out there, a one and done GLP-1, we called it, the Rejuva program from a metabolic therapeutics company called Fractyl Health. And I am super excited tonight that we have the CEO of Fractyl Health, Harith Rajagopalan, is here to talk about Fractyl Health's two really amazing therapies that they're working on right now. Revita, which is an outpatient endoscopic procedure designed to resurface the lining of the duodenum and targets the root cause of type 2 diabetes and obesity, as well as Rejuva, which we build as the one and done GLP-1. We'll see how close we are with that framing, which is a novel gene therapy platform aimed at establishing long-term remission of obesity and type 2 diabetes by targeting pancreatic islet cells. Super excited to welcome Harith in. Harith, welcome.
Thank you so much. I'm so happy to be here.
Yeah, we're so honored that you're giving some time to the community, Harith. OnThePen is a community of patients living with type 2 diabetes and obesity. We effort to basically just take all of the information that's put out there, typically for investors, typically for the medical community, but not a ton out there for people living with the diseases of obesity. So we try to basically just translate all that information into something that somebody can take and sit down and just have a more competent and intelligent conversation with their doctor about. So it's a pleasure to have you here. And I know that you've got a hard out time today. So I want to jump right into some of the exciting things that you're doing at Fractyl Health. At Obesity Week, you had the opportunity to present on the Revita program, which is the first one that I mentioned before we brought you into the stream here. Harith, can you tell us a little bit about that procedure and how you see that sort of addressing some of the current concerns with anti-obesity medications?
Sure. Yeah. So Revita is a outpatient endoscopic procedural therapy, as you mentioned. It targets a region of the gut called the duodenum, which is the first portion of the small intestine. It's right after the stomach. And it's the first part of your body where sugar and fat actually get absorbed. Because of course you eat something, it goes into your mouth and then down your feeding tube, esophagus, into the stomach. It doesn't get absorbed there. The place that food begins to get absorbed is in the duodenum. And the brain knows this. And we've evolved to have nerve fibers connecting from the brain down to the duodenum so that the brain can have an early warning signal of what food is coming, what types of food are coming, how much is coming, so that it can help prepare for the food that's about to be absorbed. Imagine like if you drank a Frappuccino from Starbucks and then you went in your stomach and then you threw it right back up again, unfortunately. None of that would ever get absorbed into your body. It's only when it passes through the stomach into the duodenum that it actually gets absorbed. So the duodenum is a critical metabolic signaling center. And it turns out that the duodenum is not designed for our modern diets that are very high in fats and sugars. And so lifetime of exposure to fats and sugars leads to changes to the lining of the duodenum, which then drives people towards obesity and type 2 diabetes. And what we've done is we've figured out that the lining is diseased, and we've developed a procedural therapy that targets that lining to precisely deliver energy to alter that duodenal lining in a manner that can durably improve your obesity and your type 2 diabetes. So that's what Revita aims to do.
Very interesting. So if I'm understanding you correctly, when you ingest food, it goes through your stomach, it enters the duodenum, and it basically has cells within the duodenum that go, hey, you're eating this, you're eating that. And it signals to the brain how to respond biologically to that nutrient intake. And if I'm understanding you correctly, people living with type 2 diabetes, people living with obesity, something within those cells gets broken, off kilter, abnormal function, right?
Exactly. And if we don't fix that thing, then everything else that we're doing is managing the downstream symptoms of the disease. All the drugs that we take are addressing the symptoms of the disease, but the upstream root cause is sitting right there in your gut.
Very interesting. Now, I'm curious, this probably all started with a hypothesis, right? Can you give a little bit about your background?
Sure. So I'm a physician scientist by training. I studied cardiology and then started to see patients with cardiovascular diseases. And as you know, a lot of people with cardiovascular disease have coexisting obesity, type 2 diabetes. And so I saw all of that in my clinic. And what I started to think about is how there's something that's upstream that's driving people to have obesity, cardiovascular disease, and type 2 diabetes. And our ancestors very rarely had these diseases, and now they are so prevalent, largely driven by modern changes. And I stumbled across a type of surgery that your listeners may have heard about called bariatric surgery, which is a surgery that was developed for weight loss that was also starting to show remarkable effects on diabetes and other aspects of metabolic disease. And it became remarkable, right? That the surgery on the gut, it's not touching the pancreas, it's not touching the brain, but somehow it's changing the way the brain thinks about processing food. It changes the way that the pancreas functions in order to help control blood sugar. And yet it's a surgery on the gut. So it's our scientific delving into what is going on in bariatric surgery that allowed us to begin to realize that the duodenal mucosa or the lining of the duodenum is a key upstream root cause of the disease. And this is personal for me as well. My father had type 2 diabetes and my uncle had type 2 diabetes. And so it's sort of like a light bulb went off when I saw bariatric surgery, because all through medical school and residency and fellowship training, we're taught that you got to worry about your hemoglobin A1C in type 2 diabetes. And it's only after all of these years of medical training, would you believe it, that I realized actually hemoglobin A1C is like a symptom of your disease. It's kind of like measuring your temperature if you've got a pneumonia. You can lower your temperature with Tylenol, but it's not going to make the pneumonia go away. You got to treat the pneumonia if you want to actually get better. And yet we're doing a lot to manage the HbA1c symptom we're not doing anything today to truly address the cause of why the HbA1c is elevated. That's what we were aiming to do when we set out to build this company and started working on Revita.
Very interesting. So really science that's evolved out of the previous decades worth of work in the bariatric surgery realm led you down this path. Now, with talking a little bit more specifically about the procedure itself, what exactly are you doing when you go in there?
Yeah, so most people have had a endoscopy for one reason or another, or will have had an endoscopy for one reason or another. So in an endoscopy, you go to see a gastroenterologist and they insert a camera in order to take a look at your gut. Oftentimes that's a colonoscopy and they're looking for colorectal cancer, and that requires this complicated prep beforehand. But what we're talking about here is an upper endoscopy where the camera goes in through the mouth, past the stomach, and then into the small intestine. And alongside that endoscope camera, we deliver a catheter that we've built that is precisely designed to treat the lining of the gut. What we do is once the gastroenterologist puts the catheter into the appropriate location within the gut, we've got a system that's sitting outside of the body that drives the delivery of heat energy through that catheter to very carefully and precisely treat the lining of the duodenum with a temperature that causes the layer of the duodenal lining that is diseased to become damaged, but doesn't cause any damage to the deeper structures of the duodenum. And what that then allows is the body to begin to regenerate a healthy new lining over the next several days, replacing the diseased lining with a new lining that doesn't have the changes that were caused by a lifetime of exposure to fat and sugar. For a patient, it means don't eat anything after dinner the night before, go to a local gastroenterologist in order to get an endoscopy done. It's about a 45-minute outpatient endoscopic procedure. Go to the recovery room afterwards and wake up from the sedation, and then you go home and you go back to your daily life immediately thereafter.
Wow, that is very interesting. So very minimally invasive. Sounds like any pain within this trials reported?
Most patients do not experience symptoms. Those who do end up having mostly mild or moderate symptoms, and the types of symptoms you would expect to have from an upper endoscopy in general. So a little bit of throat discomfort, a little bit of abdominal discomfort, lasting 1 or 2 days, almost always self-limited.
Great. Last question on this one, and then I want to move on into our last couple minutes on the other program that you got working there. How do you see this particular procedure fitting into the current landscape of anti-obesity medications and type 2 diabetes treatment? Is this a replacement for, say, current anti-obesity medications? Is it a replacement for current diabetes medications?
Well, I think that Revita is quite different from medicines in a key way. I think that these medicines, as I mentioned before, are addressing downstream symptoms of the disease. And what's true for all of these medicines is that when you stop taking them, the effects stop working. What Revita aims to do, because it's aiming to reverse a upstream root cause of the disease, and because it's an outpatient procedure, it'll have lasting effects that don't rely on whether people are taking the medicine or not. And so what that does is it offers a potential to change the trajectory of the disease. As you know, diabetes is a progressive disease. It gets worse over time. Even if you take your medicines perfectly, eventually those medicines stop working and then you need to escalate medical therapy. So many people end up in a unending pattern of more and more medications in order to manage this progressive disease. And what we aim to do is to break that pattern of chronic medical therapy by addressing a root cause. So if you can intervene early enough, it might avert the need for medicines in the first place. Or if you intervene later in the disease, you may offer the ability for people to be able to control their disease better without needing to keep escalating their medicines.
Very interesting.
In obesity, we're running a study right now where we are asking whether Revita can be an off-ramp to the anti-obesity GLP-1 drugs. And, your podcast is called OnThePen. So I guess one way to think about it is the REMAIN study is asking, can people safely get off the pen? And the reason we think that this is an important question is because, as you know, a lot of people discontinue GLP-1 drugs for one reason or another. And sometimes it's because of cost, sometimes it's because of access, sometimes it's because of side effects. A lot of people are asking the question, how do I keep the weight off if I have to stop taking these medicines? And right now, there's no good answer to that question. And so Revita aims to be the first therapy that tries to offer an off-ramp by allowing people to, and what we're doing is we're testing whether if you stop taking the GLP-1 drug and we randomize patients to either getting the procedure or a placebo procedure, whether they can keep the weight off for a 1 year period of time without regaining the weight. Because prior studies of drug discontinuation have shown that people tend to start regaining weight pretty rapidly.
Very interesting. This is a more beneficial procedure for somebody with type 2 diabetes than maybe it would be for your average person living with obesity.
I guess I would say that the duodenal dysfunction in the duodenum is an upstream root cause of both obesity and diabetes, because duodenal dysfunction signals to the brain and then makes people feel hungry in a way that can't be satisfied, but also drives blood sugar higher in ways that cannot be controlled. So I think that Revita could be a really compelling treatment option for both types of patients. I wouldn't restrict it to one or the other, but it offers different types of benefits depending on what you're looking for.
Very interesting. Really looking forward to the data that comes out on the sort of maintenance end of GLP-1 therapies using the Revita program. That's a very fascinating avenue that you're going down there. On the Rejuva topic, so Rejuva is your one and done GLP-1. Can you give a quick flyover to a bunch of non-medical people what this treatment is and sort of how it addresses some of the issues with the current anti-obesity treatments out there?
Sure. So GLP-1 is a hormone. Everyone makes it, and you make it in your gut. And the cells that make it are endocrine cells. They're hormone-producing cells that sit in your gut and make a ton of it, and then only release it when the body needs it. When you've eaten a meal that has fat or sugar in it, then it releases GLP-1 into the bloodstream. And there it has effects on the pancreas and in the brain in order to lower your blood sugar and make you feel full. So that's how GLP-1 works normally. Now, there are drugs, the anti-obesity medicines, that are mimetics of GLP-1, as you say. And what they do is they drive very high levels of this chemical that mimics GLP-1 and keeps those levels very high all of the time. Those drugs are great. They can lower your body weight. They can lower your blood sugar. They can have a lot of other benefits too. They work like your native hormone, but there are also those key differences in terms of what those levels are and how long they last. So what Rejuva aims to do is to try to mimic more the normal physiology of GLP-1. And the way that we do that is by delivering DNA directly into the pancreas, and in particular, the cells of the pancreas that make insulin. And what the DNA does is it teaches those cells how to make GLP-1 and how to package it and release it in a way that is just like those cells release insulin and mimics the way that GLP-1 is normally released from the gut.
Sorry to interrupt, but just out of curiosity, I did sit in on your lecture at Obesity Week, and not being a doctor, it's difficult to track with everything. But to clarify, is this treatment sort of programming your DNA to make endogenous GLP-1, or is it programming it to make the analog version?
Yeah, it's programming your beta cells to make natural human GLP-1 hormone. Okay. That's what it's designed to do. And it's one way you might think about it is like hormone replacement therapy. Okay. In people with obesity and in type 2 diabetes, the natural GLP-1 that you make is thought to not be working that well. And so what we aim, and certainly the amount of GLP-1 that our ancestors needed in order to process their diet living in the Serengeti, savanna, was totally different than the amount of GLP-1 that our bodies need for our modern diet and lifestyles that we're living in right now. So what we aim to do is to just amplify the amount of GLP-1 that your body can make so that your body can do a better job of managing the diet and lifestyle that's consistent with our modern lives, rather than the diet and lifestyle for which we were evolutionarily designed.
So you're essentially training your DNA to make more endogenous GLP-1. Obviously, with the analog versions, semaglutide, tirzepatide, there's sort of this lipidization process that makes it sort of impervious to DPP-4, right? And so you talk a lot about root causes, getting to the root cause of disease, and obviously DPP-4 run amok in the guts of people who are diabetic is a huge issue, with just having good levels of endogenous GLP-1. So is it just like orders of magnitude larger amounts of GLP-1 floating around in your bloodstream? Because you presented some data that was very compelling as to how this treatment stacked up with once weekly semaglutide.
Yeah,
I get into that if you'd like, but how in the pharmaceutical versions, you just have basically a very long half-life of analogs. Here, you're just making a lot more of it.
Yeah, it's such an interesting question, right? Like the question really boils down to, what are you trying to accomplish? Okay. If you're the GLP-1 manufacturer, what you're trying to do is you're trying to accomplish, how do I deliver this kind of benefit? And so people only have to take the pen once a week. If the native GLP-1 hormone only sticks around for a couple of minutes because it gets broken down by the enzyme DPP-4, as you say. Right? So what you need to do is you need to go through tremendous lengths to be able to make a drug that can fit into a pen, be injected once a week, and last long enough to be around for that whole week. And so that's what you're talking about, the lipidization and the DPP-4 resistance and all of the other things that the drug manufacturers do in order to make the drug last. But what if instead what you really need is just more of your native GLP-1 timed to when you need it and regulated in the normal way that GLP-1 is regulated in the body, so that there's more of it when you need more and less of it when you need less. The way that we try to do that is by delivering it in the way that we do as a gene therapy. And what that does is it essentially takes advantage of the body's own DNA and its own physiology to be able to now regulate the amount of GLP-1 that is produced to the amount that the body needs. And one of the cool things about the gene therapy that we're developing is, if over the course of time, your body doesn't need that much GLP-1 in order to be able to function normally, then the body will not produce extra GLP-1 because it's all regulated only on demand. And that's not true for the drugs, because the drugs aren't actually fixing the underlying biology in a way that allows you to ever stop taking them without extraordinary effort. And I think that that's a key differentiator about how we approach GLP-1s versus how the drug companies approach GLP-1s. And we talked about bariatric surgery earlier. Like, one of the ways in which bariatric surgery is thought to work is by increasing the amount of GLP-1 released after meals. And that helps sort of control body weight and blood sugar and all of the other benefits of GLP-1 biology, but in a way that is producing endogenous GLP-1. We're endeavoring to do exactly the same thing.
And so in other words, your body's producing more GLP-1 natively, but it's still nutrient stimulated. You still have to eat to release the GLP-1. It's not as if you just always have an exorbitant amount of GLP-1 floating around.
That's right. I mean, and in fact, one way to think about it is insulin. Everyone's body makes a certain amount of insulin at baseline, low level amount of basal insulin is what we say, right? And then if you eat a meal that's high in fat and sugar, then the brain knows, okay, I've got to start mobilizing myself so that I can not have all of that fat and sugar sitting in the bloodstream. And one way that it does that is by releasing insulin from the pancreas when the body needs it in order to put away the fat and the sugar so it's not circulating in the bloodstream all the time. So the beta cells know how to do that by responding to blood sugar and then releasing insulin in response. And what we're doing with the Rejuva gene therapy program is to basically replicate that, but also to release GLP-1 at the same time. And what's important to say, maybe the most important thing, is it seems to be working in preclinical models that are predictive of what we would expect to happen in humans. So you alluded to some of the data that we showed at Obesity Week, where we compared a single dose of the Rejuva gene therapy candidate versus chronic administration of semaglutide in the obesity mouse model that people use when they're developing drugs for obesity. And what we showed is that when you give a single injection of the gene therapy, it can lead to greater amounts of weight loss and longer lasting weight loss than what you can get from semaglutide. But what we also tested was what happens in these mice when you stop semaglutide and then give them, sort of separate them into two groups and then say, okay, we're stopping the semaglutide. We're either going to give you a placebo or we're going to give a dose of the gene therapy and see what happens. So mice that get semaglutide lose weight, improve their blood sugar, all very nicely. But the second you take away the semaglutide, they regain all of their body weight and their blood sugar goes right back up to where it would have been had they never gotten the semaglutide in the first place. Whereas the animals that then switched over to get the gene therapy are able to maintain all of those benefits without needing the lab technician to go in and inject them with semaglutide chronically like they had been doing. And so you now translate to what happens if you're able to show that in people. I think these drugs are amazing. Don't get me wrong. I think that what they have proven is outstanding. But what you can't escape is that these drugs are not delivering the same kind of value in the real world as they've shown in clinical trials, because the whole system has to work perfectly for you to match what the clinical trials show.
Right.
Your doctor needs to prescribe it on time. The pharmacy needs to have it. You need to pick it up on time. You need to take it on time. When the insurance company raises questions about it, you got to write the letter in order to make sure that you can keep getting it. You got to keep paying for it. And you got to do that forever for that to work. Now, that's a lot of effort. And perfection in this world is really hard, as you know. So
you're speaking our language right now, for sure.
Right? So instead of relying on perfection, which is a million good choices between now and the rest of your life in order to make sure that the GLP-1's working for you, could you instead imagine making one good choice to undergo our therapeutic intervention, to get the gene therapy into the pancreas and then allow the pancreas to do the work for you? That's the core question that Rejuva asks.
Yeah. Wow. Really, to sort of encapsulate this all down, Fractyl, what makes me so excited about what you're doing there is its current anti-obesity medicine science and current bariatric surgery science meets and sort of intersects into these therapies that, honestly, as a patient who lives with diabetes, a young guy, I got 4 young kids. When I think about the future of life, living with this disease, your treatments, your therapies that you're working on probably get me more excited than anything that I've learned about in this space. And I'm so thankful that you were willing to come on and help spread the word about what you're doing, because this information is going to be very, very meaningful to many, many people. My last question for you, Harith, is obviously there's no way to tell in this moment what these types of therapies will cost, but can you just answer, do you think that payers will be more, PBMs will be more apt to cover a procedure like Revita, like Rejuva, over how reticent they have been to adopt GLP-1 analog treatments especially for obesity?
I can't speak for payers, but what I can tell you is that a question we're getting all of the time for our Revita product, when we are talking to insurers, is how do we de-prescribe GLP-1s for our obese patient population? And the reason they're asking that question is because, A, it's costing a lot of money, obviously. And I think a cynic can say that's where the reason they don't want to pay for it starts and stops.
Mm-hmm.
But what I hear from their perspective is so many people stop taking them that they don't know who's actually going to benefit and who's not. And so they're spending a lot of money on drugs that are actually having a short-term impact on body weight. And then when they look at electronic medical records, they are not seeing improvements in cardiovascular disease or kidney disease in the way that the phase 3 trials would have predicted. So in my view, a reckoning is coming that is necessitated by the fact that we now have electronic medical records that allow us to understand very clearly what works in the real world and what doesn't work in the real world. And Yogi Berra said, in theory, there's no difference between theory and practice, but in practice there is. And phase 3 trials are still theory, but practice is the real world. And the real world means who's going to benefit, how do I know they're going to benefit? And in my view, device-based procedural therapy and the procedural interventions, one-time interventions, shall we say, that don't rely on an infinite number of good decisions, all parts of the healthcare system, are easier to translate into practice than all of the best theory from clinical trials that require a million things to go right.
Very, very fascinating. Harith, I'm very, very grateful for the time and especially the extended time that you gave to us today. Is there anything else that you'd like to mention to the community before we hop off?
Well, I'm touched by what you said about you having type 2 diabetes and having 4 young kids. And I would say that part of what drives us at Fractyl is the idea that we think that everyone who has a disease should have a right to live a life free of disease. I think that the highest aspiration for a patient is to not have to be a patient. And the only way that you could offer something for obesity and type 2 diabetes that turns a patient into a non-patient is to try to develop therapies that aim to end obesity and or type 2 diabetes for that patient when they've undergone the therapy. And that's what we aim to do. And I would stipulate what we aim to do is just so fundamentally different than what others are aiming to do in the category that's what's differentiated about who we are. Because I think about people like you and I think, how can we help you not have to be a patient? I think about my dad and my uncle who had type 2 diabetes and then complications of type 2 diabetes. And I think what they really wanted was to not have diabetes, not to be given more tools to manage it, better drugs to take it, things that can help them understand their diabetes better. Of course, like in the absence of something that actually works, you want all of those things. But actually what they really want, if you ask them, is to not have to have obesity or type 2 diabetes anymore. So how do we get to that place? That's what we're obsessed with trying to figure out.
I love that. I love it. Very, very exciting. Thank you for the work that you're doing at Fractyl. And thank you, Harith, for spending some time with us today. I really appreciate it.
Appreciate it. Thank you so much.
What a wonderful conversation with Dr. Harith Rajagopalan of Fractyl Health. This was one of the most fascinating conversations that I've had on the pen so far. I feel like I'm saying that more and more every week. I think it's more of a testament to the quality and the caliber of guests that are coming on and doing the show here. So thank you, Dr. Rajagopalan. Thank you to Fractyl Health for being willing to share with the community some of the very exciting things. As I said in the interview, from the patient perspective, some of the most exciting things that are going on in the space are the things that Fractyl Health is working on. To think of a procedure that could, potentially be a game changer for somebody living with diabetes or obesity. And I love what they're doing. So check them out. They are Guts on the stock exchange, GUTS, and Fractyl Health. They are a metabolic therapeutics company. Definitely worth checking out. Thanks again to Fractyl for coming on the stream tonight. Thank you for being the best part of what we do here at OnThePen. Couldn't do it without you. Please give the podcast a 5-star rating and review if you enjoyed this, found it beneficial anywhere. If you're watching on one of the platforms, whether you're watching on X or YouTube or Facebook or LinkedIn, make sure you give us a follow. We do tons of content just like this, and there will be more and even more exciting things on the horizon here for OnThePen. So thanks for joining me today. I really appreciate y'all hanging out with me, and I really appreciate the time that Fractyl Health gave to the stream. Y'all have a great week.